Hello everyone. Today I am going to talk about azathioprine, which is very commonly used nowadays as an immunosuppressant. We will learn about what should physicians check before starting a patient on azathioprine. Azathioprine is an immunosuppressant and immunomodulator. FDA has approved it for symptomatic treatment of active rheumatoid arthritis and also as an adjunctive therapy for the prevention of kidney transplant rejection. It has also many off-label uses like inflammatory bowel disease, Churg-Strauss syndrome, autoimmune hepatitis, chronic immune thrombocytopenia, lupus nephritis, connective disease, tissue disease associated interstitial lung disease, and many other diseases. Metabolism of azathioprine in a simplified form. Azathioprine is a purine analog that converts to its active metabolite mercaptopurine non-enzymatically. Mercaptopurine then converts to thioguanine with the help of enzyme hypoxanthine guanine phosphoribosyltransferase transferase. Thioguanine is the most active metabolite and it is responsible for most of its actions and side effects. Thioguanine gets incorporated into the DNA, causing inhibition of DNA, RNA, and protein synthesis. Mercaptopurine also gets converted to thiouric acid with the help of xanthine oxidase and into methyl mercaptopurine with the help of thiopurine S-methyltransferase. Methyl mercaptopurine and thiouric acids are inactive metabolites of azathioprine and they don't lead to any of the side effects. So if suppose there is any medicine which blocks this xanthine oxidase, like xanthine oxidase inhibitors like allopurinol or febuxostat, so more if they inhibit this xanthine oxidase, more and more mercaptopurine will be converted to thioguanine, causing increased side effects of myelosuppression. Similarly, if a patient is deficient in TPMT, then again same thing happens. Mercaptopurine gets converted to more thioguanine, causing more side effects and myelosuppression. Azathioprine is absorbed rapidly through gastrointestinal system and therefore it is available as both oral and IV preparation. It does not penetrate blood-brain barrier. It metabolizes in liver and excretion is via the kidneys. Therefore, renal failure increases its toxicity. Now we'll look into the contraindications of azathioprine. They are hypersensitivity, pregnancy or plan for pregnancy. Contraception is recommended. But in many situations, giving azathioprine is better because the benefits are higher compared to the harms. And therefore, in many conditions, it is continued also. Breastfeeding, unknown TPMT status or deficient TPMT activity. Almost 1 in 300 people have no TPMT activity, and another 11% of population is having deficient TPMT activity. And therefore, in those patients, if azathioprine is given, it can cause myelosuppression, which is even difficult to manage. It should not be given in any person with known malignancy because azathioprine in itself is a carcinogenic agent. It should not be given in any clinically active infection. Relative contraindications. Allopurinol or febuxostat intake because it can cause severe myelosuppression. Next is cyclophosphamide or chlorambucil treatment in the past because it increases chances of liver cell necrosis. Side effects which are seen in 15 to 20% of patients. Nausea and vomiting. Nausea is the most common side effect. The tablet should be given after meals. It can also cause fever, fatigue, arthralgia, and myalgia. Next is bone marrow suppression. WBCs are the most commonly affected. This complication correlates with the thioguanine level. An increase in mean cell volume of the RBCs is also seen. Hepatotoxicity, which can be of two types, either idiosyncratic liver injury, which happens in early course and it resolves completely with stopping the medication. Or it could be nodular regenerative hyperplasia, which occurs in inflammatory bowel disease and organ transplant patients after years of therapy. Next is nephrotoxicity. And next is hair loss, which is often seen in transplant patients receiving the drug, but rarely in other conditions. Now, the rarer side effects. So, photosensitivity, including skin cancer, 60 to 90% of transplant patients are affected after around 20 years of transplantation. Patients are found to be abnormally sensitive to UV light because of accumulation of 6-thioguanine in the DNA. Cutaneous hyperkeratosis and non-melanoma skin cancer are seen in myasthenia gravis, solid organ transplant, and IBD patients. There are reports of cases of hepatosplenic T-cell lymphoma, which is a rare and very aggressive type of lymphoma, usually in patients with IBD. Adolescents and young adult males were the majority of cases. Usually, there is no lymphadenopathy in this lymphoma. Patient presents with constitutional symptoms, cytopenias, and hepatosplenomegaly, which makes very difficult to diagnose it early. Acute pancreatitis, which can happen in females with Crohn's disease, usually in first 6 weeks and usually completely reversible after stopping the medication. Under FDA rules, the use of this drug excludes eligibility for blood donation. It is listed as a group 1 carcinogen. Now we'll read about its interactions. So other purine analogs such as allopurinol and febuxostat, which inhibit xanthine oxidase, increase the toxicity of azathioprine. Azathioprine decreases the effects of the anticoagulant warfarin and of non-depolarizing muscle relaxants, but it increases the effect of depolarizing muscle relaxants like succinylcholine. It can also interfere with niacin, causing pellagra. So, mercaptopurine actually decreases the synthesis of nicotinamide adenine dinucleotide, NAD, and nicotinamide adenine dinucleotide phosphate, which are key coenzymes in the niacin metabolism, and therefore it can cause pellagra. Live vaccines are contraindicated during azathioprine treatment. In fact, patients who are on azathioprine, they should avoid contacts with those patients who have taken live vaccines or having any severe infection. Tests which are done before prescribing it. It is CBC, LFT, RFT, TPMT activity. Now, misclassification of TPMT phenotype can occur in patients with prior blood transfusion because TPMT activity is measured in the red blood cells. HbA1c for hepatitis B, anti-HCV for hepatitis C, PPD skin testing for tuberculosis. Now, in countries like India where tuberculosis is endemic, it is better to go for a chest X-ray rather than PPD skin testing. Patient should be asked to report back to you in the following situations. If he is having high fever, cough, sore throat, extreme fatigue, there is any kind of bleeding from gums, nose, in urine or stool, or pinpoint red spot on skin, that is petechiae, having severe abdominal pain, severe vomiting, and anorexia. While the patients are on regular treatment, there are certain tests which have to be repeated. So these tests are CBC and LFT. So initially, it should be repeated every week for initial 4 to 8 weeks. Thereafter, it should be repeated every 3 months. It should be repeated more frequently in patients with kidney disease, elderly, patients on high doses of azathioprine or low TPMT activity. If leukopenia is there, WBC count is less than 3000 or platelet is less than 1.2 lakhs or SGPT or SGOT is more than half of the upper normal limit, the medication should be stopped. Serum amylase should be checked only if the patient complains of severe abdominal pain or nausea, vomiting to rule out pancreatitis. Lymph node and skin examinations should be biannual. Some salient points on medication. It usually requires 6 to 8 weeks for azathioprine to work. The recommendation is to consider stopping the medication if there is no improvement in 3 months. If a generalized wart occurs, the azathioprine dose should be reduced or it should be switched to another agent. Thank you.